Okay, welcome to the last session of the meeting. This is Live Case 7 TAVR for challenging cases. I'm here with Eberhard. Together, the panelists are Dr. Chen, Dr. Kim, Dr. Park, Dr. Yeung, and Dr. Zhang. So we are going to Severance Hospital first for case number 12 with Dr. Cohen and Dr. Myeong-Ki.
Hello, good afternoon.
Hi.
Welcome to Severance Hospital. I'm Young-Guk, and let me introduce our team. On my right side, Dr. Myeong-Ki, and on his right side, another Dr. Seung-Jung, and we have Dr. Jung. She is our third-year fellow. We have a supporting staff of nurses and technicians, and also our anesthetist will help us throughout the procedure. So let me introduce our case. We have a 93-year-old male patient presented with several months of dyspnea on exertion, NYHA class 2, and the patient had coronary artery disease, which was treated with stenting at mid-LAD and Vista RCA, and the patient has also paroxysmal atrial fibrillation, and he received a pacemaker implantation back in 2018. And during the evaluation for TAVR, we found lung cancer, and this will be further evaluated and treated after TAVR procedure. Next slide. And the patient has also diabetes, hypertension, hyperlipidemia. The STS score is 7.3, and Euro score 2 is 1.9. And clinical frailty score is 4. The patient has limited activity. However, his physical activity does not require assistance. And serum creatinine level is slightly higher, so eGFR is 55. Next slide. And this is the X-ray and chest electrocardiogram. So the patient has obviously permanent pacemaker, and the pacemaker rhythm is visible on ECG. Next slide. And this is the baseline transthoracic echo. Peak systolic pressure gradient and mean pressure gradient was 55 and 25 mmHg respectively, and Vmax was 3.7. And AVA, estimated AVA was 0.86, and stroke volume was 33, and ejection fraction was well preserved. So the hemodynamic parameters does not meet the classical severe AS. However, when we consider the smaller stroke volume, we can say this is a paradoxical, low flow, low gradient, severe AS. And the patient has a tricuspid aortic valve. Next slide. This is the CT findings. The minimum and maximum annulus diameter was 18.7 and 27 millimeter respectively. Mean diameter was approximately 22 millimeters. And perimeter was 22.7, and area was aortic valve area, annulus area was 376. SOV, I think it is large enough, it's larger than 30 millimeters, and LVOT has similar dimension as annulus, and ST junction has diameter over 30 millimeters. Next slide. Ascending aorta has mild dilation, and then the calcification burden is not high, so the total volume of calcium is about 500 and between 300 and 500. And on the left side, the left coronary ostium height is 11 millimeters, so slightly low. On the right side, the coronary artery ostium height is 15 millimeters. Next slide. And the annular angulation is not severe, so around 30 degrees. And these are the images of coplanar view and causal overlap views. Next slide. This is the iliofemoral, the artery dimensions and the features. On the both sides, the diameter of the iliac arteries have diameters larger than 7 to 8 millimeters. So I think the iliofemoral arteries on both sides can accommodate the delivery system. Next slide. This is the coronary artery reconstruction view, and on this CT scan images, we couldn't find significant instance stenosis or significant stenosis. Next slide. So when we consider to implant Evolute Pro device, the recommended size will be 26 millimeter valve. This will be 15% oversizing. Next slide. And when we gonna use Sapiens 3 Ultra, then the recommended size is 23 millimeters, and the nominal implantation will be 8.4 oversizing. And next. And occluded Neo 2. So when you consider occluded Neo 2, then 25 millimeter valve will be the appropriate size for this case. So next slide. So I think according to the CT findings, I think we can consider all three, or recently we have also Navitor, so we can consider all kinds of valves in this patient. But since you have seen all the other valves, so I think it is for us good to show the Evolute system in this patient. And especially this patient has already permanent pacemaker, and we don't have to worry about the conduction system disturbance. So I think it is a good choice in this patient. So we routinely do TAVR procedure under MEX, so with local anesthesia and sedation. And we routinely use the eyes as imaging guidance. So in this patient, the patient has not much calcium burden, and the valve area was 0.8, so I think we don't need to have predilation. So next slide.
저기 화면 확해장 그거 보여주세요.
Great.
So do you have any questions about this case?
Maybe we can ask the panel what valve system they would prefer in a low flow, low gradient AS. I did not see a dimensional index. Was that calculated in terms of the LVOT VTI and the aortic valve VTI? So we usually would do a dimensional index just to confirm the low flow, low gradient. But nevertheless, what do people think? Would you use a balloon expandable or a self-expanding system?
I prefer a balloon expandable one because the patient has a coronary issue. The other thing is that for this patient with so many the calcific atheroma, I would use cerebral protection, though the patient is aged.
Yeah, so 93 years old. Eberhard, I know what you would choose.
Nope, you don't.
You use
No,
a
I
balloon
would not.
expandable? Okay.
Yeah, I would not use a balloon expandable valve here. It's not, and I'm not so much concerned about the coronaries. With 93, I think he lived a good life, and the chance that he's going to get the coronary disease with 93 is fairly low. So I would, as far as low flow, low grading is concerned, I don't think we have any reliable data to suggest one valve over the other. So I go along with their choice.
Dr. Chen?
Well, yeah, I mean, Evolute is a very good choice because it's superannular. Well, we started off our program with core valve many years ago, so we have favor of the Medtronic type of valve. But anyway, small annulus, superannular valve is always my favorite type of choice because usually you have much better flow and much better gradient. And also one more point to note is, with the Evolute FX system, they got gold markers and it's a good way to have all these commercial alignment. But of course, I agree with Eberhard that 93, we don't need to bother about that sort of things, even though it's a low height. But the patient diagnosed to have a cancer of the lung, presumably it's going to be a curative surgery. We got cases that the patient got some metastatic lesion. We are not very sure about the real prognosis. Then I think a palliative balloon, BAV, may be another option to consider, just to have the patients better hemodynamic to tie over the surgery. And then, in our locality, we tend to observe that we need to have 1 year lifespan expectancy before we can, do this sort of quite expensive TAVR implant. It's just my view.
Choice?
I really choose the septic expander because she has a small annulus, so maybe the superannular system is more EOA for her. So I choose the septic expander system.
Okay.
Ellen, and you?
For low flow, low gradient, I sort of the postulation is you want to get the gradient to be lower, right? So I typically choose a self-expanding valve in this situation and get as low a gradient as possible because that's kind of at least the theory is that if there's something not basically working in terms of the valve is not opening well, of the cardiac output is low, so I want to get the lowest gradient and get hopefully some relief on that part. Again, I would say coronaries are not an issue in 93 and has a pacemaker, so it should be a relatively, hopefully straightforward and smooth procedure. The only question I have is, would you pre-dilate in this 93-year-old? The valve is a little calcified. A lot of times I just prefer just do a pre-dilatation and done with that, and then deploy the valve. But that could be, obviously a concern. But for 93, also cerebral protection is could be tricky because usually this is very tortuous, and I just don't want to waste time on that.
Okay.
Okay, so back to you, Dr. Ko and Dr.
So
Hong.
as I mentioned, according to in our opinion, his aortic valve calcium burden is not that high. So and the valve area is 0.8. So I think we will have no problem to pass the aortic valve with delivery system. So I think we don't have to do the pre-dilation in this case. So our plan is implantation of Evolute system without pre-dilation, and if probable leak, significant probable leak is observed, then we can still post-dilate. So that's our plan. And as Dr. the chairman already mentioned, in this patient has small stroke volume, and to reduce the gradient, I think it is an important point. And also this patient has a small annulus, even though this is male patient with not small body figure. So it's a little bit interesting. So I think in this case, I think Evolute system is a good choice.
And how will be your implantation days? I'm Dr. Yin. Sorry, interrupt you.
Yeah, and the last point is this patient has relatively low left coronary artery ostium. So, but the SOV is large enough, so we don't consider the coronary artery protection.
I mean, what will be the implantation days predetermined?
Implantation.
5 or 6? I mean.
It's a common.
I think 5, 6 is comfortable.
Because the permanent pacemaker was already done.
Mm-hmm. Yeah.
And we'd like to emphasize of this patient is quite different the patient with a severe aortic stenosis. I'd like to emphasize the characteristic paradoxical low pressure, no flow, no gradient. Actually, this patient was superficially benign and simple, but after the valve deployment, suddenly changed, collapse, and changed the malignant, and it is the disaster. So I'm a little bit nervous during the valve deployment. It's a quite different change of it.
So the paradoxical, low flow, low gradient AS is attributed to small cavity of the LV and the restricted, the relaxation of the LV. So that's why the patient has more stroke volume. So one of our imaging specialists has some concern about suicidal LV, but I don't know whether it can happen. But anyway, according to literature, the immediate outcomes does not show any significant difference between this type of AS and other classical type of AS. However, long-term outcome is poor in patients with small stroke volume.
박회장의 스크린을 보여주십시오.
Okay, then we're going to proceed with the procedure. So I'd like to show the baseline aortogram. So this is the co-planar view.
Pacemaker and ice.
This patient has already permanent pacemaker, but for the rapid IV pacing, we inserted the temporary pacemaker through the right interjugular vein, and we inserted ice through the right femoral vein into the right atrium to have the imaging guidance.
Could you show the eyes on the screening? Eyes finding?
Yeah,
Okay.
this is the longitudinal view of aortic valve. Okay, you can see the longitudinal view of the aortic valve and also some part of the LV. So we are going to proceed with the procedure.
Next.
Dr. Ko and Dr. Hong, I just have a question, I'm sorry. Are you protecting or you plan to protect the coronaries with a wire, or would you leave them alone?
In this case, we don't need to protect the coronary artery because, as I said, the SOV is larger than 30, or almost 34. So, and we are going to use 26 millimeter the Eberhard system. So I think there is enough space. So I think I don't worry about the coronary obstruction during the procedure.
Actually, the coronary height is 11. Is that there's some risk of the coronary obstruction after the valve deployment? Okay, let's see what happened when we use the self-expandable valve in this patient.
I think the commissural alignment is the most important thing in this patient. Yeah.
Good comment.
Okay, yeah, that's important. So the next image, we during the catheter insertion and wire change, suddenly the wire
Just
suddenly went into the LV
That is the technique of the master.
without additional effort. So I was lucky. So next image. Next, Andrew. Okay.
Next.
Okay, we inserted pigtail in the LV and we checked the hemodynamics before the TAVR procedure. So LVEDP is about 15 millimercury and there is about 15 millimercury gradient in systolic pressure. Okay.
Okay.
So.
Yeah, then definitely no predilatation, right? So it's
Yes, I don't
once,
think it is necessary.
Obviously,
in
we
this
change
case.
our mind sometimes as the procedure goes along.
So the pigtail is already in the LV, so I will insert a safari wire.
Eberhard, do you use the Safari or do you use the Comforter?
Usually Safari. I just, maybe we let them deploy and then we can maybe discuss.
좀 하나 더 해주고.
You know, the predilatation, I'm not talking about it just to pre-dilate, but to see how the leaflets behave with regards to the coronaries.
Like do a little injection and see how things are
tum을 다
there.
풀어줘. 좀 프로로 좀 보여줘.
Especially if it's low, then it gives you some confidence, right?
Exactly.
자, 밸브 주고.
Dr. Hong, do you think from the ice you can see the coronary flow? You have a 4D ice in color. And I'm just curious because sometimes when we have TEE, that's one of the advantages that quickly you can see whether there's any left main flow, but it may be hard to see that.
It's
detail
the
from
high
ice.
level of technology.
Yeah.
So sometimes we can find, but not every time.
Yeah.
Actually, we experienced the
AP를
700
놓고.
patient, and so far, we are still accumulating our experience. And we would like to show you the ice finding.
You don't have the FX still, right, in Korea?
No.
Yeah, this is Pro
This
Plus.
Do you have
yes,
FX now?
This is Pro Plus.
Yeah, but do you have FX available or not? Still not available?
No, not available.
Okay.
천천히. Now we are trying to the commissional alignment.
Okay.
Okay.
So this is the head marker is facing the great curvature. Okay. Implantation view.
엑시스 맞춰. 엑시스 맞춰.
네. 줌 놓고.
엑시스 좀 더 맞춰줘. 좋았어. 자주 올려줘. 더 돌려줘.
In this situation, Eberhard, or would you use LV pacing so you don't have to put in another, pacing wire from the neck since he has pacemaker already?
Yeah, we basically always do.
LV pacing. Yeah, but here, good, perfect situation.
Yeah.
You don't need to have the backup type
Yeah.
of thing.
조금만 더 들어가야 돼.
And Safari wire is pretty good for LV pacing because there's multiple contact and stable.
Right.
So this is your cusp overlap view, I presume.
No.
This is
No? Oh, you
popular
want-
view. Yeah.
I'm sorry.
Three cuts view.
Okay.
The
You don't
patient
use cusp overlap.
wanted big
Actually, the pacemaker was the permanent pacemaker.
Is in the way.
Yes.
Sometimes you can still get a near cusp overlap view and get the pacemaker out. But I feel comfortable to check it on that side because this can be misleading sometimes on the non-coronary cusp
Yep, yeah.
location.
If you use the wire for
Okay.
pacing,
Yep.
then
자,
when you
Histogram.
aim high, sometimes you need to pull back the wire. What will you do
So-
when you?
Yeah,
What do you think about this?
I think
histogram?
because absolute pacing is relatively 120, and you can once you kind of have this location, you may not need it. So I think it's probably okay.
I
If
think,
you orient
this
on the
depth is
non-coronary, I think this is nice.
Okay.
천천히.
Do you have a near cusp overlap view to just check just for our interest for the audience, or it's too hard to get to that stage?
Yes.
일단 집중해.
So we want to focus on deployment first. 야, 조금만 당겨줄까?
I guess
저
that's
약간 위로 올라갔어.
Just release it.
the non-coronary is.
아, 풀어진 것 같은데. 풀어진 건가요?
하나 더.
오케이.
좋아. 어휴.
페이싱 업.
페이싱 업.
We heard that.
오.
빼주세요.
자, 천천히.
So will
Okay, take a
post
picture.
slide?
No.
No.
아유.
You see, when we deploy the evolute, there is a little bit of upward motion. It's almost be the annulus. So if we do the post dilation, there is a chance of the migration.
So you use the inline sheath for this one, and now you're putting up sheath back.
This is just a small sheath. Okay.
Okay, it's time to check with
thermo.
Did you use your ice to look at the location of the valve?
Okay, we will show it. We will change about the
zoom하고.
That's pretty good.
Okay, good. 됐어요. 그렇게 해놓고. 자, 이제 아이스 보여. 저기 픽테일을 좀 주소 여기 바꿀까? 여기.
언론 해야 될지 모르겠네.
말로 하지 마.
일단 나이스.
자, let's check it.
Okay. This is the longitudinal view.
메인 화면에 아이스를 좀 보여주십시오.
Flow.
Look at the-
flow.
Look at the ice finding on the screening.
Yep.
Okay, this is the
Actually, this is a long axis view. Color is actually there is no probable leakage so far. And when you look at the distal margin of the valve, in the long axis view, just so almost be close to the annulus. Dr. Go, now try to the short axis view.
야, 컬러.
Color.
I think there is some
It looks like
probable leak in the LCC direction.
looks
I
like
see six,
within a
five.
valve.
Between 5 and 7.
Looks like a few dots outside.
Yes,
Yeah,
yes,
so-
5 and 7.
Yeah.
Okay.
That is the value of the ice. Immediate to check what is the
Maybe.
location and the.
Rotation을 한번 볼까요?
좋아.
So we are going to show the valve with the rotational fluoroscopy. And
줌 하나 더
check
해줘.
whether the valve is symmetrically expanded. Okay.
가.
Rotation.
더. 됐어.
Okay. So maybe we take a aortogram.
Sure.
I'm surprised.
아까 저 퍼펜디큘러하게 나오고. 그래서 거기서 좀
좋았어.
준비? 됐어요? 오케이. 레디?
almost be.
해주는 게 좋을 것 같아요.
밸브를 하나 더 준비해야 될 것 같은데. 밸브를 하나 더 해야겠어.
일단 볼룬 22mm 볼룬 준비하시나요?
아니, 밸브를 바로 집어넣는 게 같아. Actually, the angiographic finding, the leakage is quite larger. We need the additional procedure. Let me ask what is the best one for this case?
Obviously, I think it's a little high, meaning,
Right.
I think the cuts
Agree.
overlap view would have told us that, that corner was way too high, and there's no reason to be high because you have a pacemaker. So
Right.
now the risk is that, it seems that this thing is wobbling a little bit as well. So if you post-dilate it, I'm afraid that it would leave, meaning that it would be embolized.
Right. If we do the balloon dilation, and the chance of the emboli is quite higher.
I mean, there's couple choices. You can certainly, put in a balloon expandable and lock down the bottom, and makes it bigger.
Actually,
and-
this time is the balloon expandable valve is not available.
you can put in a
I
second.
would, I mean, everything that you said is right, but I would still try to post-dilate and position the balloon a little bit differently, so it doesn't, it's not too deep in the ventricle. But even though on the non-coronary side it's a little high, I think you're going to be okay. Knowing you two, I know the valve will not slip.
Yeah, post-dilate, just give it a shot because not a whole lot of choice at this point.
Yeah,
For 93 years old as well, if you can get the
yeah, it's a little bit too much.
엠볼리제이션이 확실히 될 텐데.
And I don't think
저쪽에는 다 앵커링이 돼 있어요.
I don't think it will embolize. I think on the left side you're going to be good, and I think
it might still
you'll be
stay at
fine.
0 because it needs to swing out.
Yeah,
So let me give it a shot. This whatever size, And you also have a pretty stiff wire in there, so some of that regurgitation could be from that. So
what wire is this?
this is still Safari,
Oh yeah,
right? So you
Yeah.
know that all those contrasts is hard to tell. If you want to switch it to a pigtail and see what it is, but since you put post-dilated first, doesn't matter too
더
much.
깊게 들어가죠. 더 깊게. 더 깊게.
What size balloon?
So this is 22 millimeter balloon.
Okay.
더 깊게 들어가야지.
Now you want
Okay,
rapid
so I
pacing.
will insert the balloon a little bit deeper.
조금만 더 들어가죠.
Rapid pacing.
Okay, so 180회 pacing on balloon.
Pacing off.
Pacing off.
see the valve didn't move.
Let's see what happened.
Yeah.
Confirm better.
Looks a little bit more.
Yeah, it
open.
looks better though.
So I think you should change it to a pigtail, and check your aortogram or check your ice and see whether that's better. Maybe the
So
ice
the
looks better
valve
already.
looks more expanded,
Yeah.
and
Those little dots may be better on your ice. Maybe I see one dot
On
now.
ice, the short X view, actually the
pigtail.
amount of and the severity of the paravalvular leakage at the 5 o'clock and 7 o'clock is much reduced.
Yeah.
Yes.
See.
Yes.
I saw like 3 or 4 dots before. Now I see one dot, so that's better. Let's change the pigtail. What do you think? Just so they
Yeah.
get rid of
Yes.
that stiff wire in the ventricle. You can check your gradient and get out of there before it moves.
If you look at the inflow, before that the inflow was a little constrained.
Yeah.
And now the inflow looks much better. And I was, I wasn't too,
Concern, yeah.
no, I wasn't too concerned because on the left side, the valve was still anchoring well.
So that's the debate is whether to pre-dilate, meaning sometimes, these valves that are calcified, old person that even it's not very calcified, you cross it easy. I think it's helpful to release some of whatever
Hemodynamic
tension.
보여주세요.
Look at this, that's nice.
No gradient. Awesome. Single.
So far, so good.
And good diastolic pressure. So
Yes. Really good.
에어토그램 한번 해보고. 자, 우리 저기 로테이션 플로로스코프 다시 한번 보여주지.
로테이션 해볼까요?
Well, you
We
achieve
are
to
checking
deploy it
the
high, so we get
rotation of-
하나
best
더 주고.
gradient.
오케이. 자, 로테이션.
돌려. 더. Okay. Actually,
better.
in the
This
Vista-
looks much better.
Yeah,
Yes.
it was quite asymmetrical before.
Yeah,
자,
very
다시
nice.
퍼펜디클 클라비어. 줌 하나 더 주고요.
거기다 놓고 이제.
자, 준비. 다 됐나요? 오케이. 에어토그램. Yeah.
Better.
There's some,
Much better.
It's better. I
yeah,
would leave
yeah,
it alone.
yeah.
Okay. Personally, I really don't want the post dilation. Hopefully, this patient is the valve is not emboli. Really, God help us.
No, but I think given the position of the valve, I think you've achieved the maximum result, and I think this is on the left side. We see this. This is probably going to go a little bit, will be a little bit better over time. I think that's the best you could achieve.
Yeah. Good job.
And
It's
I
actually
agree
very-
also
yeah.
with Dr. Koh's statement regarding the coronaries. He was a little bit more optimistic than me, but I'm always wrong when it comes to them.
Great.
Okay,
Yeah.
let's just show. We have a time, so show the ice finding.
Yeah.
Please enjoy it. 화면에 아이스 좀 보여주세요.
Ice-directed TAVR.
Okay, this short axis view. On this view, actually, the probable lag is not well visible. Maybe there is some spots in the LCC side, but very small.
Another advantage in the ice in the short axis, we can clearly see the shape of the valve. Is the circular or ovoid, and the circular is the ideal pattern for the coaptation of a 3 valve.
Okay, good.
Okay, and I'll go back to longitudinal view.
When we start the ice in the TAVR procedure is actually really is unfamiliar, but the accumulate our experience actually is really help us to decide what we do. And when you look at where is the lowest margin of the evolute, you show that the valve is almost be
Great.
annulus. Zero.
Dr. Hong, I have one question. So
Yes.
in this patient blood pressure is about 200. So I think it's easily required to reduce the blood pressure during implantation of a self-expanding valve.
Yeah, so actually, we worried about potential collapse after TAVR, so we discontinued antihypertensive the medication before the procedure. And so actually, just before the procedure, the blood pressure was about 150. And now the blood pressure rose after the implantation of valve.
Sometimes the patient with the paradoxical low pressure and low gradient, we experience 1 or 2 cases of the sudden collapse. So, and therefore we have to always nervous in the impression of the paradoxical low pressure and low gradient. Look at just the morphology itself is really benign, just the deploy itself, but suddenly the vital, the hemodynamics changed, we really embarrassed. So, and then we always very nervous, the finding of the paradoxical low pressure, low flow, low gradient.
Great. We will make a situation that could be potentially difficult, but make it very nice. So I think congratulations to pulling this off. And thank you for showing the ice as well, because obviously much easier without have to do, intubation and, so forth. So thanks for showing that case. Excellent job, Dr. Cohen, Dr. Hong.
Thank you very much.
Thank you very much.
우리 굉장히 시추에서
Now look at these guys.
So who got the valve?
All right. Actually, we have already finished our cases. All right. Very interesting cases. So, anyways, we've discussed before what we've done, So, this would be last cases. All right. So, we, as you know, we are getting together with our family, Faisal, Dr. Park, and Jung-Min, Do-Yoon, TAVR, and today. For our cases, invited guest faculty, guest proctors, that Cohen is here. All right, so anyway, so we're going to discuss about our cases, a very interesting one. So, Dr. Hansu, Jung-Min.
Yes, thank you.
Where's Dr. An?
Show the yeah. Let me introduce this case. This case is 70-year-old male admitted for dyspnea aortic extension, NIH functional class 3. He underwent surgical aortic valve replacement with epic valve. Size was 21 millimeter. Echocardiography showed severe AR and moderate AS of prostate valve. His BMI was 19.0 and STS score was 5.0%. ECG showed normal sinus rhythm and chest X-ray showed no remarkable finding. Echocardiography showed motion limitation of the prostatic valve and regurgitation flow. And LV ejection fraction was normal, and transaortic max velocity was 3.2. Color Doppler showed whole systolic regurgitation volume, and this is the severe aortic regurgitation. True inner diameter was 17 millimeter, and valve inner area was 555, and inner perimeter was 84.9. Ratio of sinus and annulus area is 2.5, and ST junction to annulus was 2.0. Ratio of LVOT to annulus was 1.6, and calcium volume was 143.
Very small, right?
Yeah. And coronary height is quite low of left coronary artery, 8.9. And when we use the 20 millimeter valve to coronary distance from left coronary artery was 6.2. And when we use 23 millimeter, 5.6. And both femoral iliac artery were visible to assess. And recommended size of the balloon expander valve is 20 millimeter valve. And this is sizing table.
20 millimeter.
Yeah, and recommended size of the self-expander valve is 23 millimeter valve. And this is sizing table.
Perimeter, 23.
Yeah.
Just 12%, 13% oversizing, right?
Yeah.
Perimeter, right? So.
So now this is our planning.
Okay, interesting cases, epic valve and 20, and so we're going to plan the evolular self-expanding 23, and mainly, AR component, not too much calcium. So actually, when we started our cases, we have some, consideration about in the stent fracture first or in the later after TAVR procedures, that's the issues. And so, David, you've done what you've done.
Yeah, well, did you tell them we didn't do the case?
Yeah.
The patient had an infection.
What do we do for this case?
We're doing a virtual procedure, right? You're
Exactly. We had a lot of nice discussion about how to do this procedure for this, and it's a small valve, 17 millimeter true ID. And we thought that it would be very reasonable to try to put in a self-expanding valve here to try to optimize the hemodynamics. The patient is pretty young and relatively healthy, 70 years old, with no other major comorbidities that we discussed. And so giving him a good hemodynamic result we thought would be important. And the discussion really came down to whether we should, whether we should fracture the valve or not. And I guess that's why they wanted me to come here, because I taught them how to fracture the valve 7 or 8 years ago. I don't remember how long ago, but for it. And so what I thought would be reasonable, it's perfectly reasonable case to fracture the valve. The epic valve is very fracturable. Even though the coronaries are very low, the sinuses were quite large with VTCs of 5.5 to 6. And what we know, if we fracture the valve, what we usually get in terms of growth is about a 3 millimeter net growth in the ID. So if we fractured this valve, it would go from a 17 up to about a 20, which would still leave us plenty of valve to coronary clearance. And so the plan that we came to, that we were going to do if the patient didn't have a fever, was that we were going to implant the core valve, the evolute, and implant it a little bit on the low side because we don't want it to be too high and risk, if we do something like fracturing, to have it jump out. And then we were going to measure the gradient to make a decision about whether to fracture.
So when I, in the auditorium, I discussed with Bini Pop, and so this is just the same cases, and so what would you do that? And so maybe 60–70% of cases, just like you mentioned, is we do stem fracture first. And so at the beginning, we're going to do the stem fracture first, using the 20 balloon. And so what, you've done just the,
I've never done fracture first. There's nothing wrong with it. It's just a little, you worry about, what we worry about, which probably is maybe not so worrisome here, is, if you really tear a leaflet, when you do that, the patient could get very sick and have to work very quickly.
So you want to do the 23 balloon R, deploy the first, and remaining pressure gradient more than 10 millimeter, and so you're going to do the,
that's what I felt. There are people, so the people who I worked with in Kansas City, Keith Allen, Adnan Chachawala, thinks that we should fracture them all to make the valve, the TAVR valve, deploy better, and so that the leaflets, there's no pinwheeling of the leaflets or those sort of things.
Can I ask a question to the whole team as far as valve modification or valve cracking or whatever you call it? Are you a fan of before or after?
I'm a fan of after. We've only done them after in my experience, and mostly, the benefit of doing them after is you can assess whether you need to, right? So you can.
Your planning is first, stem fracture first, and you suggest, after the
So because you can decide whether you need to. Otherwise, you're committed.
So
the disadvantage of it is that you can, if you're not careful, you can harm the TAVR valve, and so you have to make sure if you're going to fracture after having done the TAVR, and that's what we did when we did the cases a couple of years ago. You have to make sure that especially if it's an evolute, you have to make sure that the valve is mostly in the ventricle, the balloon is mostly in the ventricle, because you don't want to tear the shaft.
David, in Colombia, you do pre, and in St. Francis, you do post.
I don't know what they do in Colombia, because I don't do procedures there. At St. Francis, we do post, and in Kansas City,
that's why I was asking the question.
So one piece of data that might be helpful is that, when was this surgery done again?
15 years ago.
15 years ago. So presumably this valve has functioned well for him for 14 years, whatever, right? So the gradient was not high. He was doing okay. So I don't see why this has to be fractured before. Once you put in an evolute valve, you probably will get a good enough gradient. So take the risk away of injury, of you could even hurt the annula. Meaning, if this gradient has been good for 14 years, why do we think we need to do something else?
That was my feeling as well.
So we all agree with to have this opinion, and so we're going to do device first and then. So what you've done?
Yeah, absolutely. I fully
Dr.
agree. The Alan's comment is totally 100% agree. And this
All right.
patient is already valve was wearing, and 14 years ago, and the main component was AR
Yes.
and the moderate AS. So after put the envelope valve and the supravalvular type, there is no pressure gradient, and the AR was fixed up. We don't need any valve fracture. Yeah, the reason why we decided to after implantation, and if the pressure gradient is more than 10, and we decide to do fracturing.
Yeah, I think it's a very reasonable way to go. And,
All right. So
it's a little safer.
What you've done? So what have you done?
If the patient has a high fever, we try to, we didn't do anything,
So hopefully the patient doesn't have endocarditis.
Yeah, we check
I was
it
going
out.
to say, that's really bad news.
Yeah. Just yesterday,
You have been
patient
talking
is
to him
okay.
too many times, don't work probably.
So we've finished just within the 1 minute, right? And so the critical signs are high fever,
yeah.
so almost
Yeah,
more than
yeah.
38,
Well,
something.
Well,
so.
actually, we're laughing about it, but I think this is a very serious question. With the bioprosthetic valve and running a high fever, it's, obviously there is a potential problem having endocarditis,
Absolutely.
and that
Yeah,
poses another
absolutely.
problem.
Yeah.
Yeah,
And
absolutely.
you have to wait blood culture, make sure that
Exactly.
if it is the case,
Absolutely.
you
Yeah.
don't put a new valve in for now. So
Yeah.
No, for sure, that's.
Maybe Duk-Woo
we talked
made
about-
rounds.
It was not an emergency procedure, it was a very
Yeah,
elective
absolutely,
procedure.
absolutely.
And maybe we're going to have some, treatment. So 1 week, 2 weeks later, David will come
I have
again.
to come. You can do it when I'm here for encore.
Okay,
You can
anyway.
put it off for a month. I won't come back.
Anyway, I hope you all enjoy our meeting, so 2 days meeting. And so really thank you for all the members joining us. And so I'm very proud of my family, including David Cohen. It's really, really, long time.
I'm honorary
friendship.
Korean.
So we're going to meet next year.
Yes,
next year
yes.
again.
Don't
So we'll
forget
have
next
more,
year our
See you
30
next
years
year, yeah.
anniversary of the
So
TCTAP.
but how would you do the next year?
Yes, and some next year our big anniversary of 30 years anniversary in our TCTAP. We prepared everything we can do, and you imagine and the big thing, and hopefully our team would like to invite sincerely everyone, and we prepared everything.
You mentioned about everything, right?
Yeah.
So SJ, you have a lot of pictures of us, so we should just take some pictures the same, and look how old we got for over 30
I'm
years.
going to make a photo.
SJ showed me my photos from 2009.
2009.
I was a baby.
Oh, yeah.
All right.
All right.
Okay.
Anyway,
Thank you very much. Yes.
All right.
Thank you. Thank you. Bye-bye. Thank you.
Bye.